let's proceed with the trephination of the frontal sinus. And this is indicated if in case there's a complication with the dehorning, such that when there is chronic empyema, okay, and this means that there's pus accumulation on the pleural cavity, and that is the frontal sinus, and that was caused by infection of the sinus after the dehorning. So there may be an aseptic, there may be sepsis while during the surgery. So even if you're doing it on the field setting, but you made sure that everything was disinfected, so you can be assured that you will not have this problem. And also, if the animal was monitored properly post-operatively, then you will not also have this problem. But you will need to do this trephination if this chronic empyema happened. Okay, so you're going to flush out all the pus that has accumulated in the frontal sinus to keep the animal alive. Okay, try to imagine like when you have colds, so your head feels really heavy, you feel dizzy, you have headaches. So that must be what the animal is also feeling when they are suffering from chronic empyema. So you are this this empyema is often confined to the caudal part of the frontal sinus, but may also happen on the entire frontal sinus. So we may need to use corneal nerve block and sedation of the animal, especially if the animal is an adult and a large ruminant. So it will be difficult to keep them very alert. Okay. So the local anesthesia may not be enough. So we need to sedate. So the animal will be more cooperative with the procedures that we will be doing. So the special instrument is the trephine. Okay. And for the patient preparation, we have to disinfect this area. We have to clip the area. And the technique in doing this trephination of the frontal sinus is to drain by making a hole or a trephine 2 centimeters from the midline, passing through the center of the orbits, okay, where we see the cross right in the middle. So that's where we're going to make the hole, okay, through trephination. So first we make a 5 centimeter vertical incision through the skin up to the subcutis and then to the periosteum. And when we reach the periosteum, we have to dissect it and separate it from the bone with the use of periosteal elevator, and draw it aside or put it aside together with the skin with the use of the wound retractors. These wound retractors are manual retractors that will be held by like a certain surgeon. If you don't have access to this wound retractor, so you may use like brand new forks and you just have to curve them out. And of course, still sterilize them, okay? And this will help, keep the skin and the muscles out of your area where you need to make the hole using the trephine. So the trephination will be performed by rotating the trephine clockwise. Okay, you first have to push it down up to the periosteum, and make sure that the pressure that you're going to put in is even, and then you're going to rotate it clockwise, okay, until you make a full circle and you separate it out from the whole frontal bone, okay? So you cut that circular groove, then retract the trephine, continue the trephination to the full thickness of the bone. So you can imagine how it can be time consuming, because this is not difficult because the bone there is thick, and how much pressure that you also have to give in order to really penetrate into the full thickness of the bone. And then you remove the disc with the bone screw. Okay. Okay, with this picture, they're doing the flashing manually, but we can make this faster by using siphoning tool. It's a plug-in, an electric an electric siphon or flashing machine. So that it will be faster to really remove all the pus or any fibrin that has been stuck inside, and to flush out an NSS. Okay, NSS that has when we use what we use for cleaning solution for the wound. So we can also put in iodine, 10% iodine on the NSS to help also disinfect the area. Okay, and also adjust for any necrosis. Post-operatively, so we are not done even with doing this once. So we have to pack the opening with a gauze bandage and to prevent any premature closure. Okay, not only to cover it like flat, but to put the gauze bandage inside the hole so that it will not close prematurely, because the pus or the bacteria will keep on producing exudates on up to 3 days or maybe up to 4 days. So we have to repeat the process several days after day one. Okay, so we have to flush it daily until the purulent discharge is no longer visible. Okay, so that's it. After which, we can close these muscles and the skin after, let's say, 5 days when the pus has already been fully addressed. Next, we have the lingual mucosa resection, and the indication is to get rid of any vices of enclosed animals. So mostly they are bored. So one of the ways on how to address these vices is through nutrition or through positive reinforcement, or what they were also doing is this lingual mucosa resection. I have not done this. Okay, the concept of this is just making the tongue smaller so that the leaking will not happen anymore, or the tongue rolling will not happen anymore. Okay, so there is a need to sedate the animal because we don't want the animal to be like alert and also aware of the surrounding, that it can still possibly move the head. So we want it to be as still as possible. That's why we need sedation for this. The animal is on lateral recumbency, and so it will be easier to manage the head as on what direction we want it to be. We have some special instruments that we will be using, such as the sponge forceps that will hold the tip of the tongue. We also need a tourniquet that will be applied on the base of the tongue, and we have the local anesthesia for the submucosal infiltration. First, we have, of course, after giving the local anesthesia, we make an elliptical incision, a few centimeters caudal of the tip of the tongue. Okay, the tip of the tongue is where we have the gauze pack, and then we have the plump sponge forceps until just cranial to the tip of the frenulum, okay, out to the base of the tongue. It's in here. You are not seeing the tourniquet because it's at the bottom, at the base of the tongue. So with the sufficient mucosa already excised, okay, you can see a convex shape or dorsum of the tongue, and then you will suture that. So to make sure that there will be, proper holding of the suture, it would be wise to also include some of the like musculature, tongue musculature. And we will oppose the wound edges using simple interrupted sutures using synthetic absorbable material. So it would look like this one. Okay. So as mentioned earlier, to prevent tearing of the tissue by the suture, so we can include some muscles so that it will hold in place. The sutures will hold in place. Okay, so the appearance now is the tongue is smaller. The diameter is now narrower than before. So it will prevent the vices that it had been doing before. So the post-op in the first 12 to 24 hours is a water only. So no solid materials, because of course it will be painful, it will be swollen, and it will be painful to touch if with solid materials that will pass through its way. But after 24 hours, the patients have really showed good recovery, and they will not really exhibit any disturbance of being offered or eating solid food. No major problems as being shown in prehension and mastication. Okay. Next, on the eye enucleation, this is one surgery that I have not done and I have been dreaming to do, But at least fortunately, I was able to witness, okay, done in a cattle. So the indication of eye enucleation is if there is neoplasia, such as the squamous cell carcinoma, if there is cross injuries on the eyeball, such as the rupture or trauma, and if there is panophthalmitis, such as in the infectious keratoconjunctivitis. So this is already a severe and progressive involvement of all structures of the eyes because of the infection. Okay, that can lead to permanent damage or vision loss of the animal. Okay, the analgesia that we can use is preferably general anesthesia. But with what I have experienced or what I've seen before is the animal is still on a standing position but sedated. Okay, so as you can see here, the word is preferably, but we usually do it in a standing sedated animal. And there's another local analgesia that we have to do, the ophthalmic and the retrobulbar anesthesia with the use of an gauge 18, 15 centimeter curved needle that will be used to infuse 20 to 30 mils of the local anesthesia. And then we have local infiltration anesthesia also of the lower eyelid and then the medial canthus. So there will be several sites that will be used for the nerve block for eye enucleation. And the position is for general anesthesia, the animal will be recumbent. Okay, so this is just to show you the retrobulbar nerve block using a gauge 18 needle that is curved. Okay, and this is doing the Peterson's eye block using gauge 18, 4 to 5 inches needle. So we have the supraorbital process on the cranial side. We have the zygomatic arch on the ventral side. And then we have the, okay, wait a moment. Yeah, coronoid process of the mandible on the caudal side. Coronoid process of the mandible on the caudal side. Okay. Do you see the insertion of the needle in front of the earwax and at the zygomatic arch? And this is to keep the eyes open and not cause analgesia on the eyes or the lids. Okay, this is also being used to remove any foreign bodies, conjunctivitis or cornea. So this is the auriculoperipheral. Okay, the eyelid is still open. The eyes are still open. Okay, let's proceed. So the technique is starting with an incision through the skin and the palpebral muscles about 1.5 to 1 centimeters from the eyelid. So that will be about 1 centimeter below the eyelid or above the eyelid. And doing blunt dissection, you have to separate all these structures away from the orbit. So this includes the globe, the bulbar and palpebral conjunctiva, nictitating membrane, and the lacrimal gland. Okay, so this is how it would look like now. You try to separate it out, all the muscles that's attaching it to the orbit. So it is entered by blunt dissection in the direction of the orbital side. Okay. Okay, continue on your blunt dissection of the retrobulbar tissues and extraocular muscles. You clamp any of the retrobulbar muscles and vessels and the optic nerve with your curved forceps. So aside from the blunt dissection, this will be the next important step. making sure to clamp for any other arteries that will be damaged, no, for any of the vessels, to address the hemorrhage, and also trying to prevent any further damage on the optic nerve. Okay, so you use with a curved forceps because the area that you'll be working around with is round, so you really need curved instruments for this one. And you control the hemorrhage by using ligation or by packing with a gauze pack. Okay. And the common one that we use actually, because it may be difficult or challenging to do the ligation. So the easier way to do is to pack the orbit with a gauze bandage, and the blood will clot. So with the pressure that you're putting in with a lot of bandages that you have to insert, and the pressure of that will stop the bleeding. So the post-operative procedure is to remove the pack in 2 to 3 days. So you will keep it there and it will look like this. Okay. So this is after the blood dissection. So it's very bloody, but you will still have to clean it. But if you see some hemorrhage happening, so you're going to pack a lot of the gauze bandage inside and you're going to leave it there. Okay. And it will look like this. And on the medial canthus, you will not suture it. So you will allot a space for a tail of the gauze pack. You leave outside for drainage. Okay. And the end result will be this induced artificial ankylobepharon several months after the surgery. So this is induced or artificial because an ankylobepharon is a congenital condition. So it's abnormal, and it shows or it presents itself after the animal is born. But since this is and so since the animal or the patient was not born with it, so then it is induced because of the eye enucleation procedure. That's why it is also artificial. Okay, so that is just to explain this statement. I've been watching you for some time. Can't stop staring at those oceans, burning cities, naval skies, lifting flares inside those oceans. Your ocean, so far. When you speak of what's I'm falling near those oceans. I've been walking the world gone by. Can't stop thinking you're kind. Careful creature, friends with time. He left her lonely at the diamond. Oh, so good. So far. When you think of so far. Time breaks your heart. I wasn't there, but I see what your girl. You showed her the world. You fell out of love and you both said, oh, she was crying with over. What I could do is hold her, holding us closer until July. I know that she loved going to good night. But I see her in the back of my mind. Oh, I believe that. Did I found things don't matter. I could go back. I never asked you was better. She couldn't be on this for me. Happy and free. Don't need to find me. You want it, sage by the driveway. Freezing gets tucked in my shirt, cause there's no obligation to make a confession. Ooh. Songs by the kitchen, radiator, with cold weather, makes you happy. Surgical hands. So there's hemorrhage, and we're trying to put in more cost back. The key here is to address the bleeding. And you can imagine that the hole that was left behind after removal of the ice is immense. So you will need the amount of gauze bandage to fill the hole. I would say you will need up to three packs of the roll of the gauze bandage to put inside, just to keep it tight. And the pressure will then adjust the bleeding. Okay, so they have it written right here. They will now close the eyelids. So I believe the drainage will now be on the caudal side of the. I know it's still on the cranial side. Okay, still on the cranial side. And more simple continuous sutures are being put in place to close the eyelids together. The suture being used here is, I would say, one of this weakness is large. I'm dealing with large ruminants right here, so sutures are so just competitions such as like fusions, so guys was done. Also expect that this procedure is really going to be bloody. So don't be surprised if you have a lot of bleeders. Just stick to what the step procedures would tell you, and make sure to have lots of gauze package to put inside the orbit. Okay, once the procedure or the suture is finished, and then you clean the surrounding areas of the eyes so that there will be less fly infestation. Okay, and now we geared towards the last part of the topic, which is on rib resection and then pericardiotomy. So this is to be done if there is traumatic reticulopericarditis or the patient is suffering from hardware disease. We can expect, so the clinical signs of such is that the animal is feverish and appetent, and it's positive with the Withers test. Okay, And by ultrasonography, you can see that there's already pus accumulation on the pericardium. And you may be lucky if you see the culprit, but I would not really expect that because that will be very difficult with the use of the ultrasound to try to find the needle that caused the that prick, no, or that caused the pericarditis. So this procedure is actually just a salvage operation just to buy time, and the prognosis is poor. So this is just saying that at least we have done everything that we could, okay? But this is not to assure that the animal will recover properly after this procedure. To prepare the animal, you should have the preoperative antibiotics, usually against the apiogenes, and the fluid therapy to prevent any surgical and septic shock. And we do the line block as to where we will be resecting the ribs. And we also need to use sedation to have a more cooperative patient. The animal will be in the right lateral recumbency. So because the left is the heart is gearing towards the left side of the plane of the body, so the access point will be on the left side. That's why the lateral recumbency will be on the right side, with a 30 to 40 degree tilt to allow drainage. Okay, so not entirely flat. So it has to be a little tilted. So for any of the blood or the pus or any of the exudate coming out, it will easily be drained. We have to do this as soon as possible, as fast as possible as well, because we don't want to address any of respiratory distress out of coming out of this procedure. First, we extend the skin incision from the costochondral junction. Okay, that is from the bottom to a point 20 centimeter dorsally on a line over the fifth or the sixth rib. So we also incise the latissimus dorsi and serratus centralis muscles to expose the rib, and we incise the periosteum and reflect it from the rib. Okay. So in short, we have to isolate the rib. We have to pave the way so that we can see the rib. Now we expose about 12 to 20 to 14 centimeters of the rib, then insert the giggly wire or obstetric wire or phytotomy embryotomy wire under the rib. And then with the saw motion, we cut we transect the rib dorsally. We grasp and break at the costochondral junction as well. So we see the costochondral junction at the bottom. So we cut to the embryotomy wire dorsally, but at the bottom part, we break it at the junction. The initial opening of the pleura should be small, and there may be a sudden influx of air that may cause the respiratory distress. So that is the air coming inside the negative pressure pleural cavity, okay, the thoracic cavity. And then we continue the incision using the blunt tip scissors to the exposed periosteum and parietal pleura for about 20 centimeters. Okay. There is an alternative technique for this. So to avoid opening the pleural cavity, do the following prior to opening the pleura. So we suture the periosteum, the parietal pleura, and the pericardium together using a two-aught chromic cut and via a simple continuous pattern. So where we put the suture lines, we incise that line in between. So meaning on the side, they will be close together, and you will only open as you will incise. In where you will incise, there will be less air rushing in. Okay. So from that incision site, pus will escape, and from foreign bodies and fibrinous exudate will also be removed. If there are any adhesions of the heart to the pericardial wall, so you have to break them gently by passing your fingers or your hand around the heart. Okay, because that's usually a sequelae when we're dealing with hardware disease. The heart, because of the pus, it usually engulfs the whole heart, and then it will attach it to the pericardial wall. So then the heart will have a hard time pumping, etc. And that is one of the causes why the animal will die. Okay. So after doing that, you have to lavage copiously with warm isotonic solution. You may also include antibacterial agents in the solution to address any of the bacteria that will be left behind. Drains may be indicated if post-op flushing is to be done. Okay, and you may close the wound or you may leave it open, and there is no need to evacuate the air that gushed in or rushed in. Post-operatively, we will need general antibiotics, and we may need to flush again depending on if there will be some exudates coming out on the following days. Okay, to conclude this topic, so the most common surgical procedures of the head performed in ruminants are dehorning and disbudding. Okay, surgeries of the head and thorax require knowledge of local infestation, analgesia, and surgeries of the head may also serve as treatment for diseases aside from giving aesthetic value to the animal. Okay, such as the usual na disbudding and then dehorning. Okay, do you have any questions for this topic? Okay. Or if none, thank you for attending. Okay, see you next time.